y'all, it's Mary. We're back with Not Just Lip Service, and I'm so excited to have our special guest, Dr. Amy Neff. She is actually next door to us, and I'm going to let her kind of credential herself, introduce herself, but our topic today is just got my wheels turning in my mind, and I am so excited to talk about this. This will most likely be a series that we do, at least 2, because there's just too much information I feel like to get out there. So Dr. Neff, why don't you introduce yourself?
Well, thanks so much, Mary. So I'm Amy Neff. I'm an integrative medicine doctor, family medicine trained, and then I also have done fellowship training in mental health.
Yes.
And so as a person that takes care of people in the mental health space, one of the things that I'm really interested in is things that work.
Yeah.
Right?
Yes. Love that.
Yes. Love
that.
Yeah. So in our practice at Mindstream Integrative Medicine, right next door to you, we basically offer, the range of therapeutic options, including, daily meds, oral daily meds. And then more recently, there have been some options that have come online that are not traditional oral daily meds, right? So people have heard of ketamine. We do it in a particular way that includes psychotherapy. And, what we understand about people is that it's not a one-size-fits-all thing in terms of effectiveness. So, not that long ago, I was reading about Botox for depression.
Here we are.
I
She
know.
said a trigger word, and I was like, tell me more. I want to
Right.
know.
Yeah. And so, my first response was like, you got to be kidding.
And I'm over here like, and she's like, no way.
Yeah. And then as I read, as I got deeper into it, it was like, oh, of course. Right?
Yes.
So, let's talk a little bit about, what we're treating first, right? Depression, very common. Probably one of the top 3 conditions worldwide that causes disability. Okay. And it really,
crazy.
Yeah. And it affects people's quality of life. And then under the umbrella of mood disorders, also anxiety disorders, trauma, and then even kind of moving into spaces of things like borderline personality disorder, something that's very debilitating and increasingly diagnosed, typically in someone who has a background of trauma, right? The reason I'm mentioning all these things is because they all actually have some evidence to support Botox for the use of treating these conditions, right? So in addition to it being a common problem, it's underdiagnosed, largely because we don't have the kind of things in the clinical space to deal with it, especially in primary care. And then of the people that take medications for it, about a third are what we call treatment resistant.
Yes.
Or they're not responding to medication.
Don't fit the mold.
They're taking the medicines, but they're not actually better, right? So when I read about Botox for depression, I thought, number one, this is something that if it's true, the clients that I serve would care about it.
Yes.
Okay. The other interesting thing was that in the clinical trials that look at this, there are patients who receive it one time and have a very durable response, right? So when we're talking about interventions that patients have to do, an example would be from ketamine, right? Most people that respond well to ketamine have to take it multiple times, and then they have to have boosters or refreshers. But there are those people that are kind of one and done. So in the Botox world, I think it's also the case that there's, at least some chance that you could have it one time and not
Be good.
really need it again. Yeah.
It's a long duration of action too, so that makes sense.
Exactly. So then in terms of for me, when I think about a medication intervention, there's this mnemonic that I use. So it's STEPS: safety, tolerability, effectiveness, price, and simplicity. Okay.
I like it.
It's it's like an easy way to think about a drug.
Yeah.
Right. So safety. So you could speak, and maybe for your podcast listeners, speaking to the safety of Botox isn't that important. For my clients who maybe have never had it.
Sure.
Right. What we can name is the fact that it's a pretty safe drug.
It's a very safe drug. Yes.
It's been used since the 70s in a variety of applications, and most of the side effects are temporary and mild.
Right. Which I'll say a lot of people think of Botox as being 2002 and, that's when it started. And it's like, oh, no. The therapeutic side, there's therapeutic and cosmetic. The cosmetic side did in fact start in 2002, but the therapeutic side has been going on for, like she said, for decades and been used in ORs and all sorts of places extremely effectively and extremely safely.
Right.
I mean, the main side effect is things that, like she said, are temporary and are having to do with usually poor placement versus actually the drug itself.
Right.
Especially in the doses we're about to discuss.
Yeah. So what you just named is something that's really important to me. If I'm going to send my clients to an office that does Botox for aesthetic reasons, but I'm sending them for this medical indication, I want to know that it's like a well-trained clinician, right?
Say it for the people in the back.
Yes. Right?
Yeah.
Where I can feel safe about that referral.
Yes.
Right? So just saying thank you for doing what you do.
We are big on that.
Yeah.
Awesome. All right.
Okay, so safety, we covered tolerability, right? So how hard is this, as the user to experience, right? So, over the holidays, I was a little blue, holidays.
Oh, yeah.
So I came over and I got some Botox.
Yes.
And, it was basically in the setting of me reading these clinical trials. And I was like, I don't like the emotional blunting that comes from the traditional, oral antidepressants.
Yes.
And so I thought, I'm 52. I'm going to go get some Botox. And I did. And it was really interesting.
Yeah.
Okay. And what it brought up, in this kind of concept of tolerability, it's some big words, but everybody's going to get this pretty quickly, is this idea of emotional proprioception. Okay. So what do I mean by that? Well, I got Botox, and within a few days, what I realized was that when I tried to move my forehead, I wasn't frowning or scowling. I have kind of the Grand Canyon.
It is not that bad. I have seen worse, but I hear you. And those 11s, we get those 11s, yep.
Right. And so what I noticed was that was kind of going away. And what I had read about in the setting of these clinical trials is that, nobody knows if it's chicken or egg, but basically you get feedback in the body from motions of your face. So if you're scowling, you're scowling. Right. And there's a feeling of that.
Yes.
Right. And so you can, maybe that's contributing to your experience of negative affect or negative emotion. Or as you move through the world, as you're scowling at people, they're kind of like,
Oh, so true. I mean, when you say it, it just makes you that is so absolutely true. And as someone who can't currently scowl right now, I can't even put my face into that. I already understand what you're saying.
Yes.
I can't. If I want to be mad or upset and I can't make that face, it really kind of automatically takes away the power of, not that I can't get mad or upset, but of just trying to do that. And it just takes power away.
Right. So there are so many interventions at this point, in the psychotherapeutic world called somatic therapy, where we're basically working with the body to try to kind of move a feeling, ease a feeling, release a feeling, surrender, And one of the problems with it is that it's a practice, right? And so if you're trying to practice that and you're really depressed, right? Motivation falls apart.
Yes, it makes so much sense.
Right?
Yeah.
And so something passive like a Botox injection has the potential just to kind of help get you in the door, right? To be able to do the next stuff that's going to help you.
Just makes, I mean, if I have anxiety, I hold it in the pit of my stomach, and having worked a little bit of trying to feel that and move it, like you said, what does it look like? Is it a color? All those things. And then trying to do it when I'm actually anxious is very difficult. It's very difficult to try to do that when you're in the moment, like you're saying. I know we're most talking about depression, but that is challenging. Yeah. I wish something could just do it, more or less do it for me in the moment, or at least help me.
Help,
right? Assist. Yeah. Yes.
Exactly. And so, so that's the nature of, again, an acceptable therapeutic, is that it has some potential to work for you, and that you can kind of agree with the nature of it.
Yes.
So then moving on to effectiveness. So basically in the clinical trials so far, they did something called a meta-analysis where they lumped a bunch of trials together.
Which I love.
And typically the purpose of that is to kind of help sift out bias. Right? And so in the meta-analysis, basically it showed that 50% of people get a response.
Which is just a crazy number.
That's right. That's right.
In the best way.
Yeah. And then about 30% go on to actually be in remission from their diagnosis.
That is significant stuff.
It's big.
Yes.
So, you know, and if you contrast that to like traditional oral antidepressants, that's a little better. Okay. Now, do we have as many people data points? No.
Sure.
Right.
Sure.
But if we go back to kind of like the features of this, like safety, tolerability, effectiveness, like we've already kind of said, it's pretty safe, right? And it's pretty tolerable, right? So in terms of what people might be willing to try, you know, it might start to have features, you know, that become acceptable
For sure.
to a person. So then price, right? And you guys can speak to that, you know, but I mean, in your clientele, you know what it costs. And if you compare the price of Botox to some of the newer antidepressants, it's actually much cheaper. Okay.
Especially the amounts we're talking about and in the area that we're talking about.
Yeah,
for sure.
exactly. And then simplicity. Okay. So think about comparing a single event of getting an injection of Botox. You
5
know,
minutes.
Right. Versus like a daily med. Okay. And what I love about this, again, in terms of the side effect profile, is that with traditional oral antidepressants, you know, I work with clients all the time who come to me that say they can't handle the emotional blunting. Okay. So from personal experience, what I noticed about having Botox was it wasn't enough to like paralyze my muscles and facial expression. And I just, you know, there was something about it that was kind of like, I noticed it, right? So I was aware of it. I could say to myself, like, I had this intention of relieving depression. And I feel it.
Yeah.
Right? And we know the power of intention.
Oh, for sure.
Like, wildly helpful. You know, and although that's never spoken to in the clinical trials, you know, I'm always putting myself in my patient's shoes to say, like, would I be willing to do that? Or what was my experience? Like, I'm way better doctor to new moms know that have had a few kids.
Oh, for sure. Yeah. And that's so important as a client or as a patient for you to have said that. That's so important to actually have experienced it and have a say in what actually we're talking about.
Yeah, exactly. Right. So, you know, so basically safety, tolerability, effectiveness, price, and simplicity. We've got something that really fires on all those cylinders, right? And then, you know, if we move into, you know, treat like populations of people that this might also be appealing to, you know, there's one population that I work with in particular that's that doesn't have a lot of options right now. And that's someone newly diagnosed with cancer for whom that life-threatening or life-shortening illness diagnosis seems to have triggered a mood disorder.
Right.
Okay. And you can understand that.
Of course.
Anxiety, depression, existential dread, even PTSD, right? Sometimes even PTSD from interacting with the medical world.
Weren't we just talking about that recently?
Yes, we were. Yes. So those are people, you know, that we now know very sophisticated meta-analyses look at patients in this category and we understand that giving oral daily medications really is no more effective than placebo. So we know it's a population that needs some support, and largely the tool that's getting kind of offered is minimally, if at all, effective, right? So, so these are options, you know, and what I'll say about that is, you know, I'd love to bring that idea, I haven't done that, but I'll bring the idea back to my integrative oncology community because as an immune therapy in certain ways, right, like as a neurotoxin that's antibody-based, there are going to be some people who are better suited to that, like immunologically. And, you know, there would be a lot of questions about patients on certain drugs like checkpoint inhibitors and other immune therapies that we'd want to kind of like be cautious about.
Sure.
Yeah. And then the other thing that I think it's important to mention is it's not very well studied. In fact, I only found one clinical trial about this, but there's a question about using botulinum toxin in patients with autoimmune thyroid disease. So Graves' disease and Hashimoto's.
Yes.
And I think that, you know, it's a well-informed patient, you know, that can make good decisions, and then maybe even a willingness to do some biohacking around this. Like, for instance, if you've got a motivated patient with Hashimoto's who would like to get Botox for an aesthetic indication or for a mood indication, you can say, hey, maybe we want to also check your antibodies.
Yeah, sure.
And see if this stirs your pot.
Right.
Which makes it better.
Absolutely. And in the aesthetic community, we don't do that enough. I mean, we hopefully ask the right questions, but people that are motivated by the aesthetic reasons, in a lot of ways, I don't want to say they're untruthful, but they're very motivated by the aesthetic reasons.
Yeah.
And so when you start turning it back into the therapeutic side in the mental health space, I think the motivation comes very differently and would be totally open. We have access as medical providers to these labs and stuff, which are simple blood draws. So I do see where, okay, let's get your blood drawn here, and let's get it after, and let's just make sure everything is good. And then to your point about, the autoimmune and the cancer patients and Hashimoto's, it's a risk over benefit, just like everything else we do in medical. Right. And then making sure we're just mindful of everyone's on the same page as the integrative oncologist, as the integrative physician, and then whoever's providing the Botox. These are not just like, and we're done. Everybody's kind of staying on as we should anyways,
right,
with what we're doing, including any aesthetic procedure. I don't need to talk to your family practice medicine to give you Botox. But in these cases, everyone being on the same page, it's relatively easy with our EMRs and with our systems and stuff to just communicate.
Right, communicate.
Yeah.
And they didn't speak to this, but one of the things I think would be helpful to mention is, like, anytime you do a therapy, right, like especially for mood, right, you're kind of creating a space of vulnerability.
For sure.
Right? It's like an uncertainty, and then you're going to respond. And again, so that's like what would make that communication really good if we're doing it for this reason.
Yes.
Right? To be able to say to the care team, hey, maybe also notice, who knows? I mean, the chances are good that there will be improvements.
Oh, for
right?
sure. Yeah.
And you just like hold space for, like, what happens if there's not, or, and that can be an issue if a person has a lot of expectations.
For sure.
Right? Like coming in like, I'm getting Botox for depression, this better work.
Yeah, this is gonna heal me, and I'm gonna be like, managing the expectations,
right,
which it is a good and aesthetic, and the aesthetic work. It's really a really nice marriage, or it could be, because we do that so intently anyways. Yes. Still, once again, for the aesthetic purpose, but it would be very easy in that particular client, knowing they're coming in for that, to flip it to helping with those. It's just a care team, which is how all medicine should be anyways. Right. But being able to communicate how that appointment with the rest of the care team, and then we already follow up with clients anyways. And so if both teams are following up, everything is good from our side, and then it rolls back into the other side. It really is just like to me, it feels very easy. Why is this not being done? Is where I'm just like, like, this is just my mind is just rolling, and I'm just so excited to even be having this conversation.
Yeah.
So.
Yeah, I love it. So the other thing that's interesting to me about the clinical studies was basically where they put the Botox. So it's not like your classic.
Oh, good. I'm glad. Yes.
Right. It's like, plan. So I showed you the picture.
Yes.
So you can speak more to kind of like the technical details.
Yeah.
Right?
Yes, for sure. And so it's still going in our glabella area, which, the paper that Dr. Neff shared with me, it's still in your typical 5-point injection area in the glabellar, which makes sense for when we're scowling. And then it was down here in our lower face. I'm fairly certain in the DO and the DAO and in the metalis, for I believe when you scowl, when people just, the negative emotions, if you understand your anatomy of your facial, the negative facial emotions that those muscles do, which are mainly here and mainly here.
Right.
And so just frowning and then scowling. And then the doses and stuff were about appropriate to actually what we do aesthetically. So
yeah. Right. And then specifically just avoiding the muscles around the eyes.
Which makes so much sense, because those are our smile lines, as people love to call them, and are what we like to, what actually shows in crinkles when we smile. So it just, it really, and then even avoiding, and it's important that treating here and treating nowhere else, aside from here, is totally acceptable. If you'd have told me, well, they're only treating up here, I'd been like, oof, because that, can lower down as our aesthetic treating nose can lower eyebrows, and I'll be like, oh, that's too bad. This is the perfect area. And then speaking more aesthetically, it also lifts your eyebrows up and opens up your eyes, which would also bear, but they may not have studied it from that aesthetic side, but that part of it coming in is like, that would help as well, because it simply, you just simply look brighter because it does lift up and stuff, which is just as helpful as not being able to scowl.
Yeah,
It
right.
makes such good sense when you really roll it all together.
Yeah, if you think back to that like emotional proprioception of what even like heavy kind of like drooping on his eyes could do. It's like,
Yeah.
you know,
Right. So to lift them up and to brighten your, and I keep going like that. It's not like but to brighten it all up is the best way to say it. I mean, God, when you tie in the aesthetic and that side of it, it's like, this makes really good sense.
yeah,
Really, really good sense.
yeah. So what this would look like for me is if I have a client that I'm working with and we're talking about mood and maybe they've taken medications for depression before, right? And didn't really have either a good experience or the side effect profile was really, too onerous, too burdensome. They were having sexual side effects or gut side effects or
So many side
sleep
effects.
right? It's like the list goes on.
Yes.
This might be someone that I would say, okay, what I'd like to do is consult Smiley, to evaluate you for appropriateness for Botox because here's the clinical trial data,
Yes.
right? And so, for my people, like, what would that experience like? We've never actually talked about this,
Sure.
but like,
That's a good point.
let's talk about that. Like,
Yeah.
what would that look like for somebody coming to you
Sure.
for Botox for this indication?
Yeah, I think it'd be a similar experience for the patient and coming in and and I think this is such a beautiful, I don't know, connection because we are very, what's the word? I don't want to say informal. We just don't want to feel like a, surgical office suite. So we're very just warm and inviting and stuff and people comment about, it's one of the best feedbacks we get is, we talk to someone like they're a person and not a patient. And I think all that can be very helpful, especially if someone's coming in for this reason and maybe has never had it before, never thought about it in that way. But, it would be a communication, like we just said, with you, with Dr. Neff about why the patient's coming in and getting a little background so that when they come, there's no, we just already have that set, and then do our own little history and physical for the, you don't take anything that's contraindicated, which there's not that we're aware of anyway. So, we take a little care and obviously autoimmune patients and stuff like that. I mean, and then you're talking about just teeny tiny little pokes, a few pokes with little needles, which can be scary for people, but it's the same size as acupuncture. I love telling people that it's the same types of needles. And, it's really a 15-minute, assuming the conversation doesn't lead us into longer, which is totally fine, but it could take 15 minutes or less to just come in and do it. And, when we consult, you don't have to do it that day. There's never a pressure, but then you can also just get it done. And it's about usually onsets in about 5 days to 2 weeks or so. So I love pointing that out. I would point this out specifically for these clients. It's not a next day. Neurotoxins take about 5 days to start and then about 2 weeks to settle in.
Right.
But yeah.
That's what I remember.
Yeah.
And it was really like subtle. Wasn't 5 days in.
It's a bell curve. Yeah. It's just like this subtle, like, oh, it's harder. It's harder. And Allergan is actually doing a study where it starts working in 2 days, and they're really pushing that it does really start working in 2 days when you look at motor implates and get down into the nerdy stuff. But yeah, it's a bell curve that it's not just like one day I'm just normal and then the next day I can't move. So it's this very subtle onset, which is really nice because that can be a little disconcerting. It's like, oh, fine, wake up and then can't move. It just slowly settles in. Yeah,
I love that. And then the way that I like to monitor response to therapy is basically just some really easy standard rating scales. Most people with a mood disorder have used them, like a PHQ-9. It's a 9-question rating scale, and it has a few extra questions in there, and there's also rating scales for anxiety, and so, what the clinical trials look at are these rating scales, right? So it might be interesting for us to kind of like use some of that, especially if somebody's coming back.
For sure.
Right?
Yeah.
Because sometimes I send people for treatments like this and then I don't hear from them again.
Oh, yeah.
I'll see them like a year later. They're like, oh my God, you fixed me. And I'm like, I wish I knew.
I think the follow-up, and that's great. Yeah. That's like the follow-up, maintaining 2 week is a standard follow-up for the aesthetic. I think, but pushing, just being super, assertive with like, we want to follow up with you. So our follow up and did it work scale, which we would work together to create, but it would be pretty standard what it already is. Is your movement less here, and can you scowl less? I mean, it's pretty simple from our standpoint. And then it's like, okay, this is kind of our starting point of now it's kind of settled in and it's working. Now we really want you to follow up, with Dr. Neff and to
I love that.
Yeah.
I love that. I mean, one of the hesitations I always have in healthcare is like, I'm not trying to create a client for life.
Right.
Like we're trying to like get you.
I love that.
Get you good.
I love that.
You know, and you know, this especially for a woman in her 50s is like kind of it was an interesting foray for me because I've never like been that curious about the aesthetic space, right? So it was a very interesting experience for me to be here, be so warmly received, have such an uncomplicated experience, and then to kind of like come away from it feeling like, you know, I think there was just this long kind of sense of abundant, you know, kind of like interest to me about this emotional proprioception. I still turn that over in my head now, even though it's like largely worn off. There's like a lingering awareness that is really interesting.
And I like that. I think that's a huge point. And we talked about this earlier, but being aware that you can't do it anymore, and even when it does come back, to your point about maybe you need it more once or twice or 3 times, that's fine. But being aware that it's not there, and then being aware, then you're more aware of when you make it. And so to your point, it's like, okay, now I'm aware I'm scowling, and how does that affect, you know, okay, am I walking around with that, and I've noticed these things. And, you know, there's always speaking to the fact that, like, we're pretty confident at this point, you know, with millions of patients, that not having your 11s or not having those wrinkles or your eyes being brighter, that alone can make you just feel better. It can just make you feel better. So now you're combining this emotional proprioception, which is just so true. I mean, it's just so true. Someone who's experienced depression, and as someone who's, now I just want to notice, like, next time it starts to wear off, I want to like test it myself. But combining those two together, I mean, like I've already said 3 times, it just makes so much sense. Yeah. It makes so much sense. I'm just so excited to, you know, just to see where this goes.
I love it.
Yeah. And to work with it. Right. And the fact that there's already clinical trials, I mean, we're super nerdy over here at Smiley. We like science, you know, that's why we're huge with Allergan. There's science-based, evidence-based fact. It's not just throwing spaghetti at the wall and seeing what works. And so some of the stuff that she shared with me in articles is just, I mean, it's there. The sample size wasn't huge, but like they've already done a meta-analysis, which is just beautiful, to try to bring things for medical providers who know about these things, to bring some of this information together and take some biases out. Then you're really like, oh, we have something here.
Right. Yeah. Right. So I don't know if you do show notes, but I can provide you with the, you know, the summary that I have.
Oh, for sure. We will, we'll put that in the caption, and then we'll get the link to something where you can click on it, and Dr. Neff's kind of summary on it is definitely what we'll do. Okay, so we're definitely going to talk more about this, because I am so excited. I can't wait to, I'll just leave it there. We haven't had enough conversations, but we'll definitely do another show on this. Comments, questions, anything. Dr. Neff, like, is right next door, not to mention we easily communicate. If you have any comments or thoughts about this, we welcome those, and can even, you know, maybe not next week, but we'll be addressing this again very soon. Any final thoughts? Not final in the sense that this is final. Right. This is not final. But any final thoughts about, I don't know, I'm just so excited. I can barely contain how just giddy I am about this.
I know.
This is just huge.
Well, it feels so good to me. You know, it's like a lot of the things that we do in healthcare, like, you know, it's kind of like we just do them because we're doing it. And there's like a momentum that kind of stays.
Oh, yeah, for sure.
And, you know, it's time to challenge that.
Yeah,
right?
I love that.
It's time to challenge it, and it's time to do it in ways that are really like patient-friendly and not necessarily focused, you know, with shared decision making, right?
Oh, yeah, for sure. And bringing specialties together, which we don't do enough. There's, you know, we try to care team things, and we really moved to that model, you know, decades ago, but we still don't do that enough. And while aesthetics is a relatively, from the cosmetic side, new in medicine, and it is relative to medicine in general, you know, this idea of marrying these two, these two fields of medicine is just brilliant. And that's how aesthetics should be looked at, as a field of medicine. It's not just that anybody, you know, you have to have a medical license, and I'll get on my little tangent here, to inject prescription medicine into people's bodies. So if we are doing that as medical providers, then why are we not, you know, let's look into it's so easy to look into other realms.
Oh, yeah. Well, think about all the off-label uses of drugs. Yeah. Like, that's a whole nother podcast.
Oh, yeah. Right? Oh, yes.
But, you know, this was, at this point, there's not an FDA indication for Botox for mood disorders, but that's why there's interest, right?
Yeah.
And just like other drugs, it's like you're giving Botox to people and you notice they're less depressed, right?
Mm-hmm.
Thank God for people noticing.
Right. Thank God for people like you looking into stuff like this. But back to your steps thing, which I absolutely love. Gosh, I wish every physician heard that, what she did with her steps thing. Botox is FDA approved for here. It just it's up for the cosmetic realm. It met everything on a high, you're talking about a 1 out of 10 on basically every single one of those. I mean, I guess we could argue price a little bit depending on on who you are, but still 2 or 3 out of 10 compared to the benefits potentially or what has already been shown and the trials already done. I mean, it's just
right. I think it's great to have it as an option, right?
Sure. Yes, that is even more important. It's not there's no one size fits all, especially in the mental health space. And being pigeonholed in any mental health space as someone who's dealt with addiction and stuff, it is so frustrating to be tried to pigeonhole into something that you don't fit into.
Right.
And so it's just for someone to be thinking outside the box is really refreshing.
Oh yeah.
So excited.
I always say I'm like the Golden Corral. Like there's a big buffet, right?
Really, yes.
But I'm not going to decide if you want cream spinach or not.
Right. Just offering you. We should, as medical providers, be offering people what is out there and the options.
And there's a realistic range of that,
For sure.
And, we don't have to kind of like get into the weeds on that. But this is it sounds like it's an amazing tool in the toolkit. And the clinical evidence is there to support it.
Love it.
Yeah.
Couldn't be said better. A tool and a toolkit with clinical evidence to back it up. What more do you really need, I think, as a client or a patient?
Right.
To try. I mean,
A place to go.
Yeah. I love it.
A good place to go.
Oh, Dr. Neff, I'm like, Carla's going to kill me because this is like, my mind is, which this is good. This is honestly timing and everything of this. I am not looking for a new project, but I just love, I love education and I love what else can we do and what else can we, do with Botox, any of it. What else can we do to make our clients better, safe for our clients, better for everything? And this is just a whole new world that I just feel like I'm just so excited. I'm excited to move forward with this and just explore it. Yeah. So we will definitely have Dr. Neff on here again. There'll be like an 8-part series coming up. She's a very busy woman, but we will have her on again. I will put all her contact information for her practice and everything in the caption notes, along with a link to her summary. And then I just look forward. I'm so grateful for you being on here, and I just can't even really contain my.
Awesome, Mary.
I know. So we're everywhere. Apple, Spotify, I better do my spiel or caller will also kill me. It's on YouTube. We'll link all of this in the description and all the places that we are. All your favorite places to watch podcasts. We'll share this everywhere. And we will see you guys next week. This will come out on Sunday at 10 a.m.
Awesome.
All right. Thank you, guys.